Are you able to hear me okay, everyone? Okay. Sorry, we're doing a couple presentations simultaneously here. And you have my screen, my slides?
Yes, I think it's still loading. But yeah, there it is. Perfect.
So I just want to reiterate that the studies were done. We have lots of data.
All right, so for today, we're going to mostly address our pediatric COVID-19 vaccine availability that we have. I do want to say thank you to Dr. Capehart. She's my colleague on the Joint Interagency Task Force for COVID-19 vaccines, and she helped with the majority of these slides. So I want to give her proper credit for that, and want to thank everyone for joining, because as we will discuss, we certainly have a long way to go when it comes to pediatric vaccination. So I always like to start with where are we at in the state of children when it comes to COVID-19. I think many a times people think that children are, not going to get COVID, or there's definitely the talk that, if they do get COVID, they're going to have a very mild case. And quite frankly, we just can't predict that. I personally am a pediatric hospitalist. I've taken care of many children in the inpatient service. I've had patients as young as 3 days old admitted to the hospital with COVID-19. I've had patients on ventilators and even ECMO, which is, obviously more advanced life support. So we've had children in our state, children and teens that have had all of that. So this is data from the American Academy of Pediatrics, as recent from 12/9. You can see there's been over 7 million, almost 7.2 total childhood COVID-19 cases. And so you can see there that represents about 17% of all cases. And so when we talk about changes in COVID cases, just between the first week of December to the second week, we saw 164,000 children test positive. So that's almost 24% of the weekly reported cases. So children are getting COVID more. And you could see here that there was an increase just in that time period in regards to the amount of COVID-19 cases. So children are getting COVID, children are getting severe COVID. We know that there are some that have higher risks. So children who experience obesity or are overweight. In West Virginia, we have a high percentage of that, but also just for the group's knowledge, a third of children who are hospitalized have no underlying comorbidity. So as a pediatrician or as any provider for any age population, it's really hard to predict who will get severe COVID. I'm sure everyone, well, maybe I'm not sure everyone, but we're tracking the Omicron variant. We just found out probably within the last hour that there is an Omicron case in West Virginia. And so we know with the spread of how that it tends to have a higher transmissibility. I think that, we have to be prepared for that. And quite frankly, we're still seeing a great deal of the Delta variant in West Virginia. So I start off with this to hopefully set the stage of the importance of vaccination in the pediatric population, and really everyone, but certainly the pediatric population, because that's our newest group of eligible recipients to the vaccines. And it's really going to take us vaccinating larger percentages of our communities to really turn the tide on this pandemic and also stop the spread, particularly with these variants. So when we talk about pediatric vaccine for 5 to 11-year-olds, the FDA further expanded the Pfizer-BioNTech COVID-19 vaccine. So it was a year ago, 2 days ago, actually, that we had our first vaccine in West Virginia, and it was the Pfizer product. And so we've now had vaccine availability for COVID-19 in West Virginia for 1 year. And so they expanded the COVID-19 vaccine to include 5 to 11-year-olds on October 29th. Then it was in early November that the CDC did recommend the pediatric vaccine for children 5 to 11-year-olds. that they be vaccinated against COVID-19. We're going to talk about how this is a different formulation than the adult version, which is incredibly important in education, but also in access and logistics, because it's different than the vaccine that we've been providing for the past year, like I just talked about. The vaccine itself was shown to be about 91% effective in preventing severe COVID and hospitalizations in children aged 5 to 11-year-olds. So I just mentioned that there's two different formulations. I think this is very important, especially for people that have been administering vaccines over this past year or at any part over this past year. So we have a purple cap formulation, which is what I like to refer to as the adolescent and adult formulation. So this is authorized, well, now approved for 16 and above, but still authorized for 12 to 15-year-olds. It's a purple cap. The dose is 30 micrograms. The Pfizer product still requires diluting. So the diluent in per vial is 1.8 milliliters, and that amounts to about 6 doses per vial. The new formulation that was authorized at the end of October and the beginning of November is the pediatric formulation. And this is an orange cap product. The dose is actually 10 micrograms. So in that prior slide where I talked about the studies of the vaccine, they found that a lower dose was able to mount a sufficient immune response, and there was significant less side effects, which we're going to talk about here in a little bit. So the actual injection volume is 0.2 milliliters. And when you're talking about diluting this vaccine, it's 1.3 milliliters. So there's actually a little bit more in each of those. There's 1.3 to begin with. So when you talk about after the diluent, you can get about 10 doses out of each pediatric vial. So what about storage? It's been a big discussion. Currently, the Pfizer product is the only vaccine that is available for under age 18. So it's the only vaccine that's either approved or authorized for that age group. So when we're talking about the pediatric populations, we're really only talking about the availability of the Pfizer-BioNTech product, which is an mRNA vaccine. And we have heard a great deal about the storage surrounding the Pfizer product because of this ultra low cold temperature that we heard so much about. We've continued to learn more that it can actually stay in that, the adult formulation for 9 months. The pediatric formulation at this time, we think about 6 months, but just as we've seen with the adult formulation, that may change over time. An interesting difference between the products is that the purple product or the adult formulation can be in a freezer for 2 weeks, but the pediatric formulation is not recommended to be in just the traditional freezer. But I think from a better logistical standpoint, the pediatric formulation can be kept in a refrigerator for 10 weeks, which is longer than what the adult formulation, which is recommended for 1 month. So once this product comes out of the ultra low freezer, it can be kept for 1 month in the adult formulation or 10 weeks in the pediatric formulation. So what about when it comes to the number of doses? So it's still 2, and the interval is still 3 weeks, 21 days apart. And then I do want to talk about additional doses because I think that's incredibly important, is that the additional dose is recommended for moderate to severely immunocompromised. So these are people who are on medications or have underlying immune conditions that would cause their immune system to not have as much of a robust. So they're recommended to have an additional primary dose, and that is actually recommended for 12 and above. They're not yet recommended for the 5 to 11-year-old population. We just saw that authorization happened. And then there's a great deal of discussion around booster doses, and I think it's incredibly important. Just at the end of last week, kind of not even with a great deal of fanfare, the CDC and the FDA authorized booster doses for 16 and above. So that would be the Pfizer product. So if it's been 6 months after their primary series, that they get a booster dose and they get that 12 plus formulation. We don't yet have booster doses recommended for 5 to 15-year-olds, but I've heard through various circles that we're anticipating probably in the first quarter of 2022 that we will see 12 to 15-year-olds be authorized for boosters. 12 to 15-year-olds were eligible for vaccines going back to May. So we're looking at those studies for 12 to 15-year-olds in regards to getting the booster shot. And as we've talked about variants, we're finding that the boosters are incredibly important for protection against these variants. There's some emerging data coming out that even the thought is with the Omicron variant, if you're not boosted, you only have about 30% effectiveness, whereas with a booster dose, it goes up significantly, even close to 90% with the Omicron variant. So we're going to learn more about the Omicron. As I said, we just learned literally this morning that Omicron is here in West Virginia, but we're going to continue to learn more about that. But I think it's really important that we're emphasizing booster doses to people who are eligible to get them, because it's going to be incredibly important to, one, can ensure people have that maximum protection, but also to hopefully also help reduce the spread and form of new variants that we're seeing. So here's just some other storage and handling considerations. So the vaccine cannot be refrozen. So once it's once it's at that refrigerator temperature, it cannot go back in the freezer temperature. We talked about it being good for 10 weeks. For those of you who give vaccine in your clinic, you have to actually write that on the vial. So that can be a little bit confusing for people. And then regardless of how it's stored, we really shouldn't be using these vaccines 6 months from the date of what's been manufactured on the vial. A change with the pediatric dose is that these vials, after you dilute them, actually last for 12 hours. With the adult formulation, it was 6 hours. And so that made it a little bit of a logistical challenge. Whereas now, fortunately, we've seen with the 12 hours, we're able to see the vaccine still be used. So I think that's a helpful logistical aspect of this vaccine, because we've heard from individuals that it's really hard to try to fit in 6 hours to get vaccines into eligible individuals. So 12 hours allows a little bit, that's a whole clinic day. So I think that's helped a great deal with logistic planning when it comes to pediatric. And so I just want to bring to everyone's attention, I think sometimes the information changes so quickly. It's really important to go back to that EUA, or that emergency use authorization document, because it has information that gets updated by the FDA. And I share it later in the presentation. And I know when Elizabeth and others share the information, that will be available to all the members. So other information that I want to share with everyone, this is a question that I get a great deal. So the correct doses is based on the child's age the day of vaccine. So we've seen this a great deal. I've worked a couple of the pediatric clinics where they're 11-year-olds and they get the first dose, and then they have a birthday and they turn 12. So you want to give them the dose of what their birthday is. These doses are based upon age. They're not based upon weight. It's based upon the age, and that's how it was performed in the studies. So I get that question a lot as well. Oh, my 11-year-old is like an adult. Should they just get the adult formulation? Or my 10-year-old? It's really based upon what their age is at the day of the vaccination. And again, the recommendation that came from the CDC is that COVID-19 primary vaccine is recommended for everyone ages 5 years and older, regardless of if they have underlying medical conditions. The one contraindication remains is that if they have a severe allergic reaction to a COVID-19 vaccine, so if they received their first dose and they had anaphylaxis, then that would be a contraindication for that second dose. When we talk about side effects, we actually anticipate to see fewer side effects. I can just tell you anecdotally from a lot of colleagues that have had their children vaccinated, they, have reported pretty mild side effects even after the second dose, which is at least in the adult population, where people tended to have a little bit more intense side effects. But the symptoms, or the side effects, or the immune responses, however you want to refer to them, are really similar to what we saw in the adult population. Pain, swelling, erythema at the injection site. You might have a fever, be tired, headache, myalgias. And we do see some lymphadenopathy as well, which, we've heard a great deal about that in regards to some of the adult formulations. So they can see some lymphadenopathy. Just as typical with the adult formulation, antipyretics or analgesic medications can be taken for post-vaccination. It's not recommended to give it beforehand. That's true for all vaccines. It's not just a COVID-19 vaccine. But I do want to just remind everyone when we're talking about the pediatric population, aspirin is not recommended because of the risk of Rye syndrome. So, I've heard a lot of people, if they have had symptoms post-vaccine, taking a little bit of a Tylenol can help in those symptoms. So when we're talking about administration, COVID vaccines can be administered without regarding to other vaccines. So I think this is incredibly important. This isn't a talk about flu vaccines, but the flu vaccine rates in West Virginia are very poor. They're around 18%, 17, 18%, whereas last year they were close to around 44% at this time. So as we come into the fall, into this season, it's incredibly concerning that we are seeing very low vaccine uptake when it comes to other vaccines. And so you can give the COVID-19 at the same time as a flu shot or other vaccines, Tdap, whatever other childhood vaccine. And you can also give them without time related to one another. So for instance, if someone got a flu vaccine on a Monday, the next Monday, they could get a COVID vaccine or vice versa. So that was a change from what we saw from when the vaccines were initially authorized, but now you can give multiple vaccines at the same visit. You just should separate them, which is standard for other pediatric vaccines. So we've seen people get this and have this, but I think it's really important that we remember this. And then I do want to bring up the location of the vaccine. Hold on one. So yes. So I think that, sorry, we're double dutying a couple presentations at the same time, and so I was being asked for on the other one. But anyway, they're covering me there. So when we're talking about giving multiple vaccines, sometimes children want to get them in their thighs. The preferred location is the deltoid or the upper arm, but we have, and I've even seen this at the clinics I've worked out, given the vaccine in the thigh or the vastus lateralis muscle. So some children feel more comfortable, particularly like the 5-year-olds, because that's kind of where they've gotten a lot of their shots, or they want to lay down. And so you can give the vaccine in that location as well. So this is just a little bit when we're talking about diluting the vaccine. You want to draw it up 0.2 mLs. I think this is really important. Depending upon the syringe you use, sometimes you can get more doses out of a vial, but you need to make sure that it's 0.2 milliliters of the vaccine, and you can't share vials. So if you're at a clinic that there's multiple vials being opened, you have to get them from an individual single vial. It's also important to select the proper needle length. So I just put this up on the slide just so that people know. For the most part, a 1-inch needle will work, and that's what's provided in the ancillary kits with the pediatric vaccine. But I think it's really important that we are mindful of the age in regards to vaccine. And then I talked about the preferred site, which is the upper arm or the deltoid muscle, but you can also consider the thigh as well. What about administration errors? They're not interchangeable. So, if a 5 to 11-year-old inadvertently got an adult dose or a 30 microgram dose, they should receive a single age-appropriate 10 microgram for their second dose 21 days later. So they shouldn't continue with that unless their age has gone up. And then if they do get that higher dose, the CDC still says it's okay to consider them completing the primary series, but that would be an error that would need to be reported in the vaccine adverse event reporting system because they might potentially see more symptoms. So here, I think it's important if somebody who is older than 12 gets the 10 microgram dose, they need to get the 30 microgram dose immediately, because the 10 microgram doses is for those under age 12. And they did here, you can see where there's the exception. I talked about you should give the dose of the age of the birth date. If a 12-year-old does inadvertently get a 10 microgram dose, it's still considered that that would be appropriate. And then I do want to just talk about myocarditis. Myocarditis and pericarditis is one of the adverse events that we have seen, particularly in younger aged males under age 30 with the mRNA vaccines. We've seen a little bit more with Moderna than we've seen with Pfizer, but I can tell you I personally cared for a child, or it was actually a teenager who had vaccine-induced myocarditis. Within a month was recovered, was admitted, but was able to be discharged in a couple days and hasn't had any longer term impacts from that. But it is important that we're counseling people about myocarditis, pericarditis. It's probably one of the most frequent questions that I get. And this is just the reporting system in West Virginia in regards to if you do experience a vaccine adverse event. And so you can also call the West Virginia Poison Center, because we at the state level kind of monitor what the errors are, because we can get access and try to intervene more quickly than when we get details from the federal level. So I mentioned the EUA, and when Elizabeth sends out the information, this will be in here. Here's where the EUAs are located. I always recommend that people go back to the CDC and the FDA. There's an EUA for providers, and there's also an EUA for parents and caregivers. And so you're supposed to give the parents and caregivers to each parent with each vaccine. And then again, really important, orange is for pediatric, purple is for adult. So, we really want to make sure that that's a distinction, because we know that some people, which is great, are starting to offer vaccine that they never had offered before. And it is complicated in regards to you have to delete the vaccine. So I do want to talk about where we're at when it comes to COVID-19 vaccines. I'm going to talk nationally and then just briefly in West Virginia. So as of December 8th, there were 4.9 million US children, 5 to 11-year-olds who had received at least one dose of COVID-19 vaccine. That's approximately 18%. We know that it varies across states, ranging from 4% to 47% receiving their first dose. I won't try to get any interaction, but we could try. I mean, where do people think West Virginia, well, maybe we'll do this if you want to drop it in the chat. Where do people think West Virginia falls in regards to where we're at in our pediatric 5 to 11-year-old vaccine rates? Anyone want to give a gander? 15%, near the bottom, low. So unfortunately, the near the bottom low is correct. So some of the CDC data is behind our West Virginia data. So from the CDC data, we would be this 4%. If you look at our state data, we think we're closer to around 10%, but we're still lower than the national average. And when you talk about vaccines of 16 and below, or even 18 and below, we're only at about 27% of our population. So we've done pretty good in the older population, above 65, we're well above 85%. But when we're talking about pediatric vaccines, we're not doing as well as we need to be, or I think any of us want to be. And so this next graph kind of shows where we're at when it talks to 5 to 11-year-olds. So this is when that vaccine was authorized, and you could see we've seen this with other age eligibility groups. We see this big uptick and we see a sharp decline, and then we just kind of plateau after it. And you'll see that here when I show the other slide about 12 to 18-year-olds. And so we have work to do. When you look at cumulatively, we've obviously continued to climb, but when you look at the weekly, we see this kind of slant, this like kind of steep slant, and then we see a steep decline. And so we want to certainly have a more sustained, we would like to see a more sustained uptick. But unfortunately, we've seen this with other age eligibility groups, and we're starting to see this. Interestingly, this population had the quickest rate of increase of other age groups. But unfortunately, now we're seeing the same steep decline that we saw with other age populations. And so what this tells me is we get the vaccine to the people who are really high on that vaccine confidence spectrum. But then, unfortunately, we see a great deal of other variability or lower vaccine confidence, and those people are not moving their intention to get vaccinated. So what about 12 to 17-year-olds? 15.2 million of US kids have actually received at least one dose. That's 61%. And then 12.8 million are considered fully vaccinated. So those two doses. So it's about 51% of 12 to 17-year-olds. As I mentioned, in West Virginia, we're unfortunately below that, about half below that. And so just based upon data that came from last week, there were about 140,000 that received their first vaccine dose this past week. So similarly, you can see this is that same graph. So this is back in May when 12 to 16-year-olds or 15-year-olds were eligible. So you see this huge uptick where we see a great deal, and then you see a big decline. And then we just kind of have seen a slow, we're really since, September, it's been pretty flat. And certainly, we would love to see this number go up as well. So as we kind of come home here and then answer any questions, when you're counseling parents about this, and I think this is really important because I have heard from different parents or different colleagues across the state that, sometimes when they go see their pediatrician or their healthcare provider, they might not be getting that strong recommendation. We know that a strong recommendation from a healthcare provider, notably your healthcare provider, is the strongest intention for someone to choose to be vaccinated. So you could imagine when someone is like, oh, well, I would wait to get my kid vaccinated. I've heard even things of like waiting for people for another formulation. Like I got a question, there was a pediatrician who recommended waiting for Novavax. Novavax is unlikely it's not going to get emergency use authorization. Once a product has been fully approved in a drug class, you can no longer emergency use authorization. So that product would have to go through full biologics approval. So I think waiting, as we talked about at the beginning, we don't know who's going to get severe COVID. So we have a safe and effective vaccine to offer now, and that's what we should be recommending for people to consider for pediatric patients 5 and above or 5 to 11-year-olds. Here again is where we talk about the myocarditis. Again, it was very rare reported. Myopericarditis is inflammation in and around the heart. And in the clinical trials, at least with that lower dose, there were no doses identified in the clinical trials. So we will continue to monitor it. These vaccines have undergone the most rigorous US safety monitoring of any vaccine in history. But in the clinical trials, we haven't seen any 5 to 11-year-olds get myopericarditis. And then I think it's important when we're talking about counseling that, the risk of the myocarditis or pericarditis after getting a vaccine is lower than the risk of myocarditis from getting the actual disease. So people frequently forget, like, what are the ramifications of actually getting the disease? We've seen myocarditis and pericarditis in people who get COVID. We've also now seen more and more long COVID. Many of the patients I've cared for that are in the pediatric population, we've had to send some to rehab centers because they've been ventilated for 3 weeks. And, they still just tell me, I'm so short of breath. And I tell them, unfortunately, that's what we've seen. And so I think it's important that we counsel on the risk of COVID and the severe COVID that kids can experience, because we also know from some of our data of understanding people's intentions to get vaccinated, if people think the disease is severe for them, they're more likely to get vaccinated. And when it comes to the pediatric population, that's what I hear all the time, oh, kids don't get COVID. Well, yes, kids do get COVID. Kids get really sick from COVID, and hundreds of children have died from COVID. It was actually one of the top 10 leading causes of death in pediatric patients. So children shouldn't just routinely die from these different types of conditions. And now for everyone 5 and above, COVID would be considered a vaccine preventable disease. So here's just some tips I wanted to share about what you can do to prepare kids for vaccines, because this is something we hear a great deal about. I encourage everyone to go to healthychildren.org and the CDC. It's important to make a plan for those of us who care for kids. How many of us despise when the parent says, oh, if you're bad, you're going to get a shot? That's not how this should be projected to the kids. It's important to make a plan and talk before, remind them the importance of vaccines, be honest and provide support. It's been very heartwarming. If you ask many of these kids why they're getting vaccinated, it's because they want to hug grandma or they want to protect their sibling who's not able to be vaccinated. So it gives me great hope for the future. And I think we all could do so much better if we listened to kids on many different topics, but really avoid telling those scary stories or making threats about vaccination, because those aren't really effective ways of preparing the child for vaccination. And then in any medical procedure with children, it's important to help them give control. So try to share a positive story about their experience. Let them know you understand their worries. Make them feel heard. Let them pick if they want to pick the right arm or the left arm. Don't apologize for getting them vaccinated. This is something that's going to help protect them, and explain to them and share it more as a positive story as to, why you're choosing to get vaccinated and why they need a good reason to get a vaccine. Ask them why they're choosing to get vaccinated or why they think it's important to get vaccinated. And then you can share those others that, yeah, you're protecting all of us by choosing to get vaccinated. And so plan for that vaccination. Some people may do better at a larger community vaccination clinic. Some of the ones that I attended were incredibly well done with pet therapy and music therapy and stickers and activities and treat bags. And honestly, some of the adults were like, could I get my vaccine this way? Because it was so well received. And so other people might do better. And I've heard parents say this, like, we can't go out in public. Like, my kid needs to be at my healthcare provider's office. So try to make it as comfortable as possible for them, if that's sitting on a parent's lap, or perhaps there's different comfort positions that you can try when giving a vaccine. There are different numbing creams and sprays out there. There's different distraction techniques, including vibration, that you can have. There's different devices that you can just put above the site that can kind of help with those pain receptors, and then encourage them to take deep breaths. I mean, the trick that I sometimes hear is, have them blow out birthday candles or have them take a deep breath and then exhale, and that can be a distraction as well. So that's what I prepared to kind of have our discussion, but I'll open it up for questions. I think there was one question I saw in the chat about aspiration. That's not recommended for vaccines in general, and it's not recommended for COVID-19 vaccines. So aspiration is not like when you're injecting, say, lidocaine or something of that matter. When you're injecting a vaccine, it's not recommended that you do the aspiration. But I'm happy to answer any questions. I guess one thing, just if I could foretell the future, I frequently get asked, when are 2 to 5 year olds going to get authorized or under? I think 2 to 5 year olds will be the next range. I don't think it'll be until early 2022. 6 to 2 year olds, there are clinical trials that are ongoing down to age 6 months, but I think we're probably thinking it would probably be second quarter 2022. But 2 to 5 year olds, I think there is a possibility in the first quarter of 2022 that we could see that authorization happen. But as usual, thank you all for everything that you're doing throughout your communities. And I'll turn it over to the ECHO team for any questions.
Thank you so much, Dr. Crystal. As always, you do such an excellent job in providing us all the information, keeping us up to date on everything in a nice manner that I can even understand. I'm not a clinician. And I now want to go run and get my booster shot, because you said it was such a big, it looks like improvement. I've been planning on it, but I just haven't done it. I'm not gonna lie. So I think there's a drive-through today.
I
So
think that's a great reminder, Elizabeth. I think we need to be telling everyone. I think if you've not yet got your booster, you really should go get it. Omicron is here. It's actually been here. We know that it's been here. I mean, now we have a confirmed case, but I think that's a good reminder for us and for our patients as well to make sure that they're getting that booster. I think long-term, and I'll say this to this group, and this has been said, I've heard this from Peter Marks and Anthony Fauci, I think eventually these vaccines are going to be a 3-dose series. So it won't be a 2-dose, it will be 3-dose series. And we see that very frequently in pediatric doses where it's common. But, we got these vaccines out to the public because we were being faced with this terrible pandemic. And so what we found over time, so I think really these vaccines will likely become a 3-dose series, which is common with vaccines, hepatitis B, whatever. But I think that, so right now we're calling them a booster, but I think long-term we will really see this become a 3-dose series. But for right now, 2 doses are still considered. There are some countries that do that differently. To be considered fully vaccinated, you have to get that booster dose. The CDC still, when it comes to mRNA vaccines, recommend 2 doses, would consider you to be fully vaccinated. J&J, it's 1 dose, but with J&J, it's also recommended now to get a booster, and that's 2 months after. Those, the Moderna only recommended for 18 and above, so I'd really go over them today because this was a pediatric vaccine talk. But I just think it's important that we're really emphasizing the importance of booster doses, as well as also making sure that people who have not been vaccinated get vaccinated. I know it's tiring to have these conversations. I've heard from so many colleagues, we don't have time. There is payment now available for counseling that you can, get payment for counseling about the COVID-19 vaccine. But we know that healthcare professionals are the most trusted source of information. Having these discussions with your patients really does make a difference, and celebrate just 1 or 2 patients that you get to choose to be vaccinated, because we still need to make sure that we get more people who have not received any doses of vaccine vaccinated.
100%. Thank you so much. And Dr. Pollywall, I see that you raised your hand. Thank you so much. Go ahead.
Thank you, Dr. Costello, for the excellent presentation. I know that the second dose should be given in 21 days, but for any reason, if you're not able to give it in 21 days, how far you can push it? I'm giving an example. For example, my nephew, he got the first dose, and then in between he got, I think, croup. And so he was sick with that. And I advised them to delay it by 1 week, just by adult experience. So can you talk about that, how far we can push and we still considered acceptable or efficacious?
Yeah, great question. And I will probably add this for the future. I should address this. So it's really that minimal period in between that we see. There's actually a 4-day grace period. I always encourage people to really wait for that 21 days. I think we will potentially even see in the future that people might, like with Moderna, wait 28 days between doses. That's how our immune system works to develop those antibodies. So there is a 4-day grace period to get it early. So, getting it on day 18 would still count as fulfilling the series. In regards to maximum length, initially when they came out with the authorization of these vaccines, because it was only studied, they recommended really only like 60 days. However, as time has gone on, it's similar to other vaccines. You can give it with really any distance between doses. And so if there is a reason that a person would not be able to get, vaccinated for whatever reason, maybe they're traveling or they're out of town or what have you, it's okay to kind of have that delay. I think it's important, I didn't mention this, it takes about 2 weeks after the last dose to be considered fully vaccinated. So, even encouraging people to get vaccinated now, if they haven't been, obviously encourage people to get vaccinated and start that series whenever. But really to get that full vaccination, it takes 2 weeks after that second dose to develop that immunity. So, obviously being more prompt, the better in regards to getting that immunity. But it's a great question. There's really not, I think we will find more. No one can speak to if a year between, at this point, we've only seen at most probably a couple months between doses, at least in the clinical trials, it was maximum, like I said, close to 60 days, 45 to 60 days. But I think at least for what we've continued to learn, that there doesn't seem to be a maximum interval between doses. It's really making sure you wait that minimum interval, at least 21 days before you get that your second shot. But great question. We saw a lot of that with the holiday schedule. There were vaccine clinics at schools, for instance. And so, when they got the vaccine and then it was like Thanksgiving break, for instance. And so people were like, well, what do we do? And so it is kind of okay to wait that in between.
Thank you so much. Great question, Dr. Polywall. Go ahead. I see you and you're fine.
Thank you.
Of course. Thank you so much. Does anybody else have any comments or questions? I only have one, and I think I know the answer, or I should. We can get a booster that doesn't match what we got, correct? And the kids, like, how's the booster?
So this is a really good question. I'm glad you asked this. So the only vaccine that is authorized for under age 18 is Pfizer. So a 16 and 17-year-old can only get a Pfizer booster. Same thing with an additional dose. The additionals are recommended to be the same product. When it comes to boosters for those who are 18 and above, you can interchange. So Elizabeth, these are perfect questions that I failed to bring up, but you can have interchangeability. So if you got Pfizer as your initial dose, you could get Moderna as your booster. You can even get J&J as the booster. I would say the data, people ask me this all the time, the mRNA vaccines do seem to have a more robust immune response. And so I do think the mRNA or getting it, if you didn't get if you got J&J first, getting a booster with an mRNA vaccine, we've seen that they have a little bit better immune response, but they can get the boosters for 18 above are interchangeable. For the pediatric population, we only have the Pfizer product right now, but great question. And I have had colleagues, and we've seen that people do that interchangeability where they've gotten Pfizer as their primary series, and then they get Moderna, or vice versa, or they got J&J, and then they get a different, they get an mRNA as their booster. So great question.
Perfect. Thank you. I'm like one of those people that like to have the same shampoo and conditioner brands. So I think it's like an OCD thing. Like, I'm like, I gotta get the same, but that's good to know. Does anybody else have any questions?
Well, actually, this is a follow-up to that question. So somebody who had J&J then gets an mRNA booster shot, then do they need a second one to complete that series?
No, because they've already completed what's considered the primary series. This is a booster. So
Okay.
They already, in theory, have immunity from that first one. And so it's not considered restarting the series. It would be just they got that booster dose. So they would be considered boosted.
Great question. Thank you so much, Dr. Rexrod. Does anybody else have any further questions or comments? If not, you're going to give 15 minutes back. So I will go ahead, but of course, anytime you have any questions or want to reach out, please do. Don't feel like you can't. And we really hope you guys have a wonderful holiday, whatever you celebrate, and just stay safe out there and just enjoy your time, but make good decisions. And I really am looking forward to the new year. And I just, really hoping it's a better year and it keeps getting better. I know it's been really rough, and I'm just sharing how I feel, but our next session will be till January 20th, and we'll have more coming up about that and what it's going to be, relating on, I'm sure it'd be the new variant or whatever other news is going on. So really appreciate everybody. Happy holidays, and thank you so much.
Thanks, everyone. Have a good holiday.
Thanks, everyone.